Hello and welcome to this live 2021 Nephrology Campus, and welcome, good afternoon, good morning or good evening from wherever you are listening to us today. My name is Christoph Wanner and I'm chairing this webinar series together with Professor Peter Stenwinkel from the Karolinska Institute in Stockholm, Sweden. So you are listening now to webinar number 4 out of a series of 18 educational webinars, and all cover the current trends in nephrology. You as attendee, you are automatically muted, but you can ask and pose your questions in the chat function. It's a button on the right corner. Today with us is Professor Francesca Mallamaci and Dr. Giuseppe Tripepi from the Physiology Institute at Reggio di Calabria. It's an institute within the CNR, Centro Nazionale di Ricerca in Reggio di Calabria. Professor Mallamaci is also the leading nephrologist at the hospital in Reggio di Calabria. Today we talk about exercise and outcomes in dialysis patients, and welcome Francesca to these webinars. And I'm inviting you now to give your first presentation on exercise and outcomes in dialysis. The floor is yours, Francesca, please.
This is a very interesting topic. Chronic kidney disease is a rising star amongst chronic disease epidemics, which are responsible for most of today's worldwide death toll. And physical inactivity, the lack of exercise, is a major cause of chronic diseases. Lack of exercise is associated to osteoporosis, degenerative joints disease, loss of neuromuscular strength, atherosclerosis, cardiovascular disease, and even cancer. But the lack of exercise is also associated to Alzheimer's disease, dementia, and depression. The physical exercise is very seldom prescribed to chronic disease patients, although chronic kidney disease is one of the most important chronic diseases. And the reason is because there are few trials in dialysis patients and CKD patients at all. In this systematic review, where were analyzed 55 trials in hemodialysis patients, these were all small single-center studies, because the vast majority of these studies had less than 30 patients, and the duration of exercise was very small. And in addition, these small single-center studies were based on supervised exercise during the dialysis session or in center. There is no trial, at least so far, testing home-based physical exercise program. And while we think that the home-based programs would be important in the elderly and important for patients' empowerment. The question is, Are low intensity home-based physical exercise of any benefit on physical performance, quality of life, and outcomes in dialysis patients? After a pilot study in a small number of patients, we set up a multi-center trial, and the results were published in JSON in 2007. This was the title of this publication was Exercise in Patients on Dialysis, and this was a multi-center randomized clinical trial. The name of this trial was EXCITE, that is an acronym for Exercise Introduction to Enhance Performance in Dialysis. This was a trial funded by the Italian Ministry of Health in 2007. The cities which were the Italian cities which were involved in this study are listed in my right. They're listed there. While Ferrara was the center of a physical rehabilitation coordinating team, and Reggio Calabria was the city where was the methodology team. The aim of this trial was to assess the clinical value of a 6-month, simple, personalized, home-based training period delivered by the dialysis staff in dialysis patients. The exclusion criteria for this trial were just physical limitation, that means amputation and or any other limitation to deambulation, and the clinical limitations like severe effort angina, stage 4, the New York heart classification, and the other exclusion criteria was a high degree of fitness. Participants were randomly assigned to 2 arms. The active arm, which was the personalized training program, and the other arm was the control, not training part of the study. The patients underwent at baseline to physical performance, which were 2 tests, the 6 minutes walking test and the sit to stand to sit test, the quality of life questionnaire, and some standard clinical parameters. These parameters were repeated at 6 months and then at 18 and 36 months. The clinical outcomes were collected for up to 36 months. Now, the performance test. What is the 6 minutes walking distance first, and the sit to stand to sit test? I start with the first one. In this test, the patient walked back and forth along a 22 meters course in a corridor as quickly as possible for 6 minutes. The second test, the sit to stand to sit test, was the time taken to stand up and sit, repeated for 5 times, as you can see in these images. The primary analysis of this trial were the major clinical endpoints and were to assess whether a 6-month home-based training intervention improves physical performance as measured by the 6-minute walking test and the sit-to-stand to sit test. Quality of life validated, the test was validated in Italian CKD patients. And then we had the secondary outcomes, but we started with the first one. The source population was made by 714 patients. The patients, which for many reasons that are described in this slide, at the end of this time, the exercise group was composed by 151 patients and the control group by 145. At 6 months, patients at risk, and if you want, we then can explain what does it mean, were 104 and in the active arm and 123 in the control arm. At 18 months, these numbers were 78 in the active arm and 84 in the control arm. At 36, 47, and 41 respectively. The randomization, as you can appreciate from this slide, went on very well because there were no differences between the two groups at baseline. Now, the results of the 6-minute walking test. In the control arm and the active arm at baseline, the results were very similar and no difference from the statistical point of view. Look what happened in the control arm at 6, 18, and 36 months. Nothing. In the control arm, no changes. Vice versa, in the active arm, as you can appreciate here, the 6-minute walking test performance improved a lot. And this improvement was statistically significant. What about the sit-to-stand to sit test? Similar results at baseline in the two groups, nothing, no variations, no changes in the control arm at 6, 18, and 36 months, while you can appreciate here from the length, from the height of the bars, that the sit-to-stand to sit test improved a lot. And this difference again was significant. These results in a pretty large cohort of dialysis patients indicate that some type of physical activity is beneficial in the performance of this high-risk population, such as the dialysis population. If we analyze the results of the questionnaire about quality of life, we looked at 19 dimensions. And as you can appreciate here, the cognitive function and the quality of social interaction improved in the active arm of this trial. What is cognitive function? Cognitive function is a broad term defined as an intellectual process by which one becomes aware of, perceives, or comprehends ideas. It involves all aspects of perception, thinking, reasoning, and remembering. Cognitive function in the control arm of this trial worsened a bit, while in the active arm there was a small improvement, and statistically significant. What about the quality of social interaction? A small regression, reducing of this quality of interaction, of social interaction in the control arm, while in the active arm, this dimension of the quality of life improved and improved in a statistically significant manner. Now, Dr. Tripepi will speak about the second part of this trial. Dr. Tripepi?
So, thank you, Professor Mallamaci, for this nice introduction to this randomized controlled trial. I think what you did was the first well-powered, large, randomized controlled trial, and we were very excited to see now these data. Now I want to remind the audience, before we come to the talk of Dr. Giovanni Tripepi, that you can ask your question in the chat function, and the button is on the right bottom. So please bring forward your question. We have sufficient time to discuss at the end with you and the two speakers. So now I'm coming over to Dr. Giovanni Tripepi, also from Reggio di Calabria, from the Institute of Clinical Physiology. And he will give us now the second part of this interesting trial. Please, Giovanni.
Dear Chairman, dear colleagues, good afternoon. The lecture of Professor Mallamaci was focused on the primary endpoints of the EXCITE trial. I will focus your attention on the secondary outcomes of the same trials. Thus, I'm going to talk about safety and tolerability during the 6-month period, as well as about death and hospitalization occurring in the two study arms over the 6 months short term and the 36 months the long term follow-up period. Here you will see a summary of safety and tolerability during the 6 months period. As you can see, the number of deaths were almost identical between the two study arms. Symptoms of moderate degree, in any case not limiting the program execution, were reported by 44 patients and included moderate fatigue, leg pain or weakness, moderate dyspnea, and joints pain. Overall, the training program was well tolerated, and across the follow-up period, only 5 telephone calls were received by the rehabilitation team across the trial. In particular, no angina episode or major symptoms complications were reported in the in the active arm of the trial, whereas no systematic collection of symptoms or complications was undertaken in the control arm. Now we move from safety and tolerability to the survival analysis, and we start by describing the results of the intention to treat analysis over the 6 months follow-up period. This analysis included all randomized patients, that is 151 patients of the active arm and 145 patients of the control arm. The outcome we considered was a composite endpoint, hospitalization death, and during this period, 58 patients experienced this outcome. In a Kaplan-Meier survival analysis, a largely non-significant reduction in the risk of the combined endpoint we adopted was observed between the two study arms. Now a look at the per protocol analysis always over the 6 months period. By definition, this analysis was restricted to those patients who completed the trial, that is, the scheduled 6-month period. Overall, 34 patients were hospitalized. In this analysis, the hospitalization-free survival was significantly higher in patients of the active arm than in those of the control arm of the trial. In particular, the incidence rate of hospitalizations was 35 per 100 person years in the active arm and 57 hospitalizations per 100 person years in the control arm, and the incidence rate ratio was about 0.60. It means that we observed a 40% reduction in the incidence rate of hospitalization in the active arm than in those of the control arm. Now we move to the results of the per-protocol analysis over the extended follow-up period, 36 months. Across this period, 126 patients were hospitalized and 8 patients died without experiencing an hospitalization before. This analysis confirmed a sustained reduction in the incidence rate of the combined endpoint in the patients in the active arm than in those of the control arm of the trial. Well, patients above 65 years constitute a growing segment of dialysis patients, and although dialysis treatment increases life expectancy, among older dialysis patients, many uremic patients suffer from distressing physical limitations. Since aging is associated with a decline in muscle mass and performance, physical exercise is considered one of the potential methods to counterbalance the age-related worsening in muscle mass and function. Notwithstanding, to date, very few studies investigated the effect of physical exercise on clinical outcomes in older patients on dialysis. With this background in mind, we specifically designed a secondary analysis of the EXCITE trial by investigating the efficacy and safety of the low-intensity exercise program adopted in the whole EXCITE trial in the subgroup of patients enrolled in the trial with an age above 65 years. As shown in this flowchart, 160 patients fulfilled the criterion to have an age above 65 years. Out of these, 83 resulted to be allocated to the active arm and 77 to the control arm of the trial. Among these, 53 patients of the active arm and 62 patients of the control arm completed the 6-month period. First of all, a look at the results of the 6 minutes walking distance. As you can see at baseline, the 6 minutes walking distance did not significantly differ between the two study groups. However, at 6 months, the 6 minutes walking distance remained almost unmodified in the control arm, whereas it significantly increased in the active arm by 35 meters. The between arms difference, which was 34 meters, was of high statistical significance and of similar magnitude to that observed in the whole group of patients of the EXCITE trial. Now a look at the 5-time sit-to-stand test. Again, at baseline, no difference was observed between patients in the two study arms. Over the 6-month period, nothing changed in the control arm. whereas in the active arm we observed a reduction on average by 3 seconds in the 5-time sit-to-stand test, and the between arms difference was statistically significant. Overall, these results indicate that physical activity is beneficial, also in elderly dialysis patients. As Professor Mallamaci already said, cognitive function is considered as a fundamental component of quality of life. Also in elderly dialysis patients of the EXCITE trial, we specifically looked at the effect of physical exercise on this outcome variable. As you can see, over the 6-month period, the cognitive function reduced in patients of the control arm and remained almost unmodified in patients of the active arm of the trial, suggesting that in elderly dialysis patients, physical exercise stabilizes the cognitive function in elderly dialysis patients. Now, some information about safety and tolerability in this subgroup of patients. 38 patients had the symptoms, again, not limiting the program execution, such as moderate fatigue, leg pain or weakness, moderate dyspnea, and joint pain. No angina episode or other major complications were observed. We also looked at the effect of physical exercise on the incidence rate of all-cause and cardiovascular hospitalizations, and we did not find a significant effect in elderly dialysis patients. In conclusion, the EXCITE trial shows that a simple home-based exercise program safely improves physical capacity and 2 relevant items in the kidney disease component of quality of life in dialysis patients. At 6 months, in an intention to treat analysis, there was no difference in the incidence rate of hospitalization death between the active arm and the control arm of the trial, while in a per protocol analysis there was. At 36 months, in a per protocol analysis, the rate of hospitalization death was lower in patients in the active group than in those of the control group. These findings suggest that the physical activity may underlie an important improvement in the risk of hospitalization and death in dialysis patients. A secondary analysis of the EXCITE trial shows that a home-based exercise program improves physical performance, stabilizes cognitive function, and is well tolerated also in elderly dialysis patients. Thank you very much for your attention.
Thank you, Dr. Tripepi, for this interesting talk and the trial. And thank you to the audience that you posed a number of questions in the chat, and we will discuss your question subsequently. So let's see. I see we have these restrictions of social distance. I'm in a big studio here with a lot of distance to techniques, so I can discuss with you. So the first questions now I have in mind is about the trial, which is difficult to do overall in dialysis patients usually. And when you designed the trial, you decided to do a home-based treatment, a home-based exercise. You gave an example to other trials which are ongoing currently, but they use in-center based exercise program. So what do you think how this approach compares to yours? And maybe you thought through this process of training?
Well, I think that the most important aspect of the home-based physical activity in dialysis patients is that this kind of activity can be performed also by dialysis, peritoneal dialysis patients, for instance, while the trials that we had so far were during the dialysis session. So the vast majority of patients were automatically taken out of these programs of exercise. So I think also CKD patients, they can have a kind of physical activity at home. And this is important also to motivate the patients. I don't know if I answered your question.
No, absolutely. Yeah. Here you need technique and devices, and this is much more feasible, certainly, and can be done everywhere. Yeah, I understand fully. Yeah. Now here comes a question from one of our audience participants to Dr. Tripepi. How did you measure the cognitive function and social activity?
We specifically measured the cognitive function and the social activity by adopting a validated questionnaire, which is the KD Quality of Life short form, which was translated and validated in Italian.
And the social activity is also within this questionnaire?
Exactly, yes.
Yeah, yeah. Yeah, I understand it's important to have validated also in other languages. Yeah. I realized that you have really good technology in reading out the performance with the 6-minute walking test and the sit and stand test, which is a simple thing, but it gives you very robust signals from smaller trials. So I was excited to have this. And this questionnaire validated, translated. Very good. There comes another question to Professor Mallamaci. How were the home exercises specified? Duration, intensity, what was the recommendation?
Maybe this was the most important part of the trial, because we had a very competent team in Ferrara which prepared the physical activity program in a personalized way. So for each patient, they prepared the exercise they thought, based on some parameters, they thought that the patients could afford. So, so it was a personalized, tailored program for each patient, and the active part of the study, the trial lasted 6 months. Maybe we could.
Excellent.
Well, I understand that for longer could be better, but in the meantime, we have to be happy with this kind of results, because, as you said, this was the first trial with this size of patients, almost 500.
Then a question to the methodology, Dr. Tripepi. Can you give us more details on the exercise program in the active arm? How much time did each patient spend on exercise each week? What type of exercise? And may I add a question, because you are also methodologist, was the missing, you cannot blind the study. Do you see an issue in non-blinding, or can it be done blinded with this home approach? So 2 questions, excuse me. More details on the exercise program in the active arm. How much time and exercising today?
The testing session was always arranged in a non-dialysis day and 20 hours after the dialysis session, either in the morning or in the afternoon. The functional capacity testing in both study arms, I mean the exercise group and the control group, were performed, as Professor Mallamaci already said, at the baseline and after 6 months. I also understand that the question is focused on having more details about how the test was implemented in each patient. And I suggest to give a look at our paper, which was published in JASN, in which there is a section of the paper which is entirely dedicated to explain the exercise program.
And the question about blinding, what do you think?
Unfortunately, in this kind of trial, the problem is impossible to do an unblinded trial. Maybe that such a choice may have affected the study results. But I repeat, it is an unavoidable problem in this kind of a trial.
Well, if I may add something, we tried to blind the patients. I mean, we said not to look each other, but to ask questions about the kind of exercise. We tried to be very, very, how you say, reserved with patients, just not to confuse the results, the final results with a mixture of I mean, if they knew exactly what the other group did, maybe the results could be completely misleading.
Yeah. Another question which comes in, what about patients with effort intolerance, for example, ischemic cardiomyopathy, or those with have problems to walk? Is it possible to do other type of physical activity?
Well, in the exclusion criteria, we said very clearly that patients with deambulation that was not good or amputated and so on, they couldn't take part to the study. And so you say it's possible to do other type of physical activity. This is a very difficult question because we excluded only amputated patients or patients who were not able to walk at all, even if they had a small, how you say, if they could walk with some help, they did the exercise. I think that other kind of physical activity for people who, for instance, are amputated could be the passive physical activity done by technicians, just to do something.
Great. There is a huge interest coming question in, but can I pose a personal question to you? First, congratulating, but to the methodologist, Dr. Tripepi. If I would give you €2 million and you could design the trial again, what would you do different? Would you put hospitalization in the primary endpoint, or what is the ideal trial?
Yes, of course. I would include the hospitalization death as the primary endpoint of the trial, because our results, at least the per protocol analysis, shows that there is an important reduction in the incidence rate of this endpoint.
Mm-hmm.
For me, this was most impressive, also as in a secondary, but I'm thinking about the future, and maybe when we get these signals, we can improve and walk in the future. Okay, so there's another question to you. How was the randomization done, and what were the home-based exercise?
The randomization was a central randomization, and allocation concealment was assured by using such an approach, because by using the central randomization, we are sure of the allocation concealment. And the nominal communication of patients' allocation in the two study arms was sent to the responsible of the single patient.
What were the home-based?
The home-based exercise.
I think you responded to this that it is all in the supplement.
Yes.
What
yes,
type
there is a
of
supplement
home-based
in
exercise?
the paper reporting all details about the methodology of the beyond the exercise.
I'm now getting a question to Professor Mallamaci, but I see that it was already discussed. But maybe let's frame it different. You did not talk about laboratory values. You did not talk about medication. Was there any maybe less EPO consumption, a change, a better phosphate, or was there any change in these parameters?
Well, we had all these parameters. We analyzed these parameters, but there were no differences in these parameters. We were looking for them, but we didn't find anything. The most important, I think that in a nutshell, the most important finding in this trial is that the hospitalization and the fact that this is a very easy way to perform physical activity, these are very important for dialysis patients, because in this nowadays that we have a lot of financial problems, these are this kind of physical activity can be easily performed without any cost.
Yeah. I see another question to Dr. Tripepi, but it was already removed because we discussed it. Okay. Now one in patients who underwent PD, CAPD, how was the exercise program scheduled?
Well, I really like this trial because we had for the first time the opportunity to give the chance to CAPD patients to do some physical activity at home. And the exercise program was scheduled as for the hemodialysis patients. And the most important point was that it was tailored to the patient. But they had the same schedule which was adapted to the ability of the patients to stick with it.
And one member of the audience asked a question, maybe you repeat the number of hospitalizations in the control and the intervention arm. How many hospitalizations were there?
In the exercise arm, the most frequent reason of hospitalization was vascular access problem. And it is the same also in the control arm. We specifically looked at to compare the incidence rate of this type of hospitalization due to vascular access problem. We did not find any significant difference. Then is the combination of the total number of hospitalization and death, which is statistically lower in patients in the active arm than in those in the control arm. But a cause-specific analysis by looking at the specific reasons of hospitalization revealed no significant difference.
Okay. I thought there were 58 versus some 40, or maybe I didn't see it. Okay. And this already was discussed, the PD question, I think, on the exercise program. So can I have the next question, please? The question is, do you have any idea about the most common cause of hospitalization among the control group? Vascular access was one.
Exactly.
And other causes of hospitalization?
Neurological reasons.
Okay.
But just
Good.
2 in the active arm and 3 in the control arm.
Small numbers, anyway.
The trial you would design next time, would it be bigger and look for harder outcomes, or why? Because you say small numbers. But this is maybe connected to the $1 million you need for a bigger trial. Okay, let's go to the next question. How do you explain that the highest improvement was noticed after 6 months, but later after 12 and 36 months, the result were in a slight regression?
This is a very tricky question, I must say. But what comes to my mind is that the compliance of the patients to the physical activity was going to be reduced over time. But this happens also with drugs, medicines, and everything. So the explanation we gave to this result was that they become less compliant to the physical activity program.
I was positively surprised that the mean age was 64 years. This is already quite high for an exercise study. Yeah. In other trials, I have seen that the selection of dialysis patients which can do this usually drives the age lower to 60 or 58. So I think 64 is also a good age, a good group, representative group that you included or could motivate to embark in this program.
Yeah, and as Dr. Tripepi has already said, we performed an analysis in a subgroup of even older patients, and the exercise was efficacious also in this subgroup of older dialysis patients. So this is a very good news, I think.
Mm-hmm. What are you doing today in Reggio di Calabria? Because you got this result, overall it was positive. You saw these many positive side effects of an intervention. Is your unit prescribing now to everybody, or how is Italy responding to your study?
Well, we after this trial, we are more convinced than before that we have to prescribe physical activity to our patients, not only dialysis patients, but CAPD patients, CKD patients, and I think that everybody, even in the general population, should have some physical activity, because we saw what the physical inactivity, the lack of exercise causes. So we are very convinced, and we prescribe physical exercise to patients, at least half an hour of brisk walking, at least. Do you agree with
how
me,
did you?
Christoph?
Absolutely. At least you need to respect the elderly, frailty, and so on. For me personally, I agree absolutely. for example, doing velo with arms is possible with non-walking patients. Do you think it is enough to get these benefits? Is another question. Different kinds of exercise.
I am sorry, but I don't understand. Velo is a stick? What? What does it mean exactly? With arms?
Bicycling with arms.
Okay. With arms.
Yes,
well,
yes.
it could be. It could be. But we don't know because we don't have a trial like the Excite with this kind of exercise. So we could do it.
Are these machines where you can cycle with arms or with your legs.
Okay.
Good. And when you talk to the huge dialysis networks, for example, for example, from Fresenius and others, how did they respond to this? Did they integrate it or try to integrate this in their treatment? It's not reimbursed. Do you need reimbursement?
Are you asking me?
No, yes, to advance this. Yeah. Do you need reimbursement for this, that it's taken up everywhere with an instructor?
Well, I think that the strength of this trial is that physical activity is easily performed at home. So I don't know if, well, I think that reimbursement is always good, of course, but in this case it's not indispensable. If I understood what you meant, Christoph.
I'm trying to find out how this excellent result of this good randomized trial can spread and give some advantage to patients. Yeah.
I think so personally, sorry.
Yeah, go on.
I was saying that maybe the good thing, the disseminating the results and let people know about the results of this trial, that is a pretty large trial, could in some way help to disseminate this the physical activity among dialysis patients. So it's a good idea.
So ongoing questions. Here is coming one. Was blood pressure measured during the home-based exercise considering the elderly age group? No, blood pressure measurement or vital signs?
At home. We just measured the blood pressure during the exercise training in the hospital, but not at home.
No.
Was there any difference pre-dialysis?
But we didn't look at this data. We have them because we have all the blood pressure measurements in dialysis, but not at home. We have also these measurements in PD patients, but I think that we should look at them. Yes, this is a very good suggestion.
Yeah, I understand that it can only be measured or best be measured before and after dialysis and over time if there's a blood pressure improvement, whether exercise has an impact on this. I think this was in the intention of the person who asked the question. Good. I think we now came to the end of all questions, exhausted. And I thank you again for doing this trial and showing us the result. This is a type of dissemination, what you are doing. And now it's our task to implement the results. So thank you again to Reggio di Calabria.
And thank you again for this opportunity to speak about this trial. Thank you.
Thank you.
Thank you. And now a short address to the audience here. Thank you for all your questions. We had exhaustive numbers, very good, and I think you got valuable information how you can implement this exercise for the appropriate patient. So we are now looking forward to the next webinar, number 5, and this is coming in November 5th, and we have Dr. Charles Chazot and Dr. Jule Pinter, and they will talk about sodium, volume, and pressure control in hemodialysis, a very important topic we are interested since a very long time, and we have prominent speakers, eminent speakers and experts who will discuss with us sodium and volume control. So thank you for your attention, and see you next time, November 5th, for the next webinar, number 5. Thank you.